Good afternoon, everyone. My name is Dr. Jodie Guest. I'm an infectious disease epidemiologist and professor and vice chair of the Department of Epidemiology at Rollins School of Public Health here at Emory University. I lead Emory's COVID-19 outbreak response team working in harder hit communities across the state of Georgia, and I am the host of Emory's COVID-19 videos, where we cover important topics about this pandemic. Today, I'm pleased to be joined by Dr. Jonathan Kim. Dr. Kim is an associate professor of medicine in the Division of Cardiology. He also holds an adjunct assistant professorship in the Division of Applied Physiology at Georgia Tech. Dr. Kim is the chief of cardiac and sports cardiology at Emory University School of Medicine and is joining me today to talk about cardiac risk from COVID-19 and returning to sports, particularly for athletes after having had COVID-19. So Dr. Kim, thank you so much for joining me today.
Dr. Guest, it's a real pleasure to be a part of this podcast and excited to answer some of these questions.
Thank you. Very quickly, before we get into talking about cardiac issues with COVID, we're going to put some numbers behind what we're seeing right now with COVID and why this is such a big potential issue for a lot of people to be considering. So quickly looking at the numbers, new cases have declined more than 80% from their peak in mid-January, which is great news. Still, daily case reports remain well above 100,000 new cases a day, which is still quite a lot of COVID circulating out in the communities. About 85,000 people are currently in the hospital with COVID-19. And the great news is that that number is declining pretty rapidly and has fallen about 30% in the past 2 weeks. And that includes both numbers for hospitalized patients and those who are in the ICU with COVID-19. After weeks of rapid growth, death reports are starting to slow down as well, although at a much slower rate of decline than we're seeing with cases and hospitalizations. We're down about 10% in deaths from the past 3 weeks, but we still have more than 2,300 deaths a day in the United States from COVID-19, which remains a tremendous burden from this particular virus. With more than 78 million people diagnosed with COVID-19 in the United States alone in the past 2 years, there are many people suffering from long-term health issues associated with COVID-19 infection. A recent study found that COVID-19 may cause heart damage in hospitalized patients with severe infection. This particular study included data from the United States, China, Italy, and Spain, and found that rates of cardiac damage were somewhere between 10 to 25% of people hospitalized with COVID-19. So let's start there, Dr. Kim. What do we know about why we have cardiac complications, particularly some that may be long-term for people who've had COVID-19? And is it always in people who are hospitalized, or it can also occur in people with mild or asymptomatic infection?
It's a really great question. I think this actually goes back to the beginning of the pandemic. And as you mentioned, I am a sports cardiologist. And one of the biggest concerns we had in the very beginning was the fact that those reports were already present, upwards around 20% of hospitalized patients having evidence of cardiac injury, which is much higher than you typically see for patients hospitalized with other common respiratory viral illnesses. So take patients who are very ill with influenza and maybe ill enough to be hospitalized from a respiratory standpoint. You don't see as much cardiac injury to the level that we were seeing and certainly still see among patients admitted with severe COVID-19. So we know that indeed, similar to having adverse sequelae from COVID-19 across the board, those patients who are older, those patients who have underlying comorbidities are the ones who are more at risk for having cardiac injury, which can be manifest in numerous different ways: release of cardiac inflammatory biomarkers, something called troponin that we measure in patients who've had heart attacks that shows evidence of cardiac injury. This isn't a heart attack per se, but it is evidence of cardiac injury, cardiac arrhythmias, weakened heart function. All of this can be seen among patients who are critically ill with COVID-19. Now, moving forward, we've learned a lot in 2 years. And one question that we didn't know the answer to 2 years ago that we do know the answer to now, which is what about patients who are not as sick with COVID, which thankfully are probably the majority of us, and certainly the younger you are, the healthier you are, are probably going to experience more milder forms of COVID-19. What we didn't know back in 2020 in the springtime, and we were fearful of, but what we've seen now is actually a much lower prevalence. We are not seeing high burden of cardiac injury and inflammatory heart disease, that being myocarditis, in younger patients with COVID-19.
Well, that is very good news, especially for the younger people watching. So among those who are younger and previously healthy without an underlying cardiac condition, is it mostly myocarditis that we're seeing with COVID-19? And secondly, can you explain what myocarditis is?
Sure. So myocarditis is a general term. It's really a disease characterized by inflammation within the myocardium, within the heart cells. And that is actually manifest with a clinical syndrome. Importantly, you really need to have symptoms. The classic symptoms of myocarditis are chest pain, shortness of breath, feeling your heart race inappropriately. We call these palpitations, other irregular heartbeats, clearly passing out of unexplained causes. All of these cardiac symptoms in association with characteristic changes on an EKG, release of these cardiac biomarkers, and even with cardiac imaging showing evidence of cardiac injury or depressed heart function. That is the constellation of the clinical syndrome of myocarditis. One of the most common causes of myocarditis are actually viral infections. So prior to COVID-19, myocarditis existed. Common respiratory viral illnesses, even the common cold in certain situations could actually lead to myocarditis in patients. And so there's a wide spectrum in terms of how sick patients can present who are afflicted with myocarditis. Now, to your question about younger individuals, again, it's important to emphasize that what we've shown, and I think really the studies of competitive athletes have shown this, are that the evidence of cardiac injury after COVID-19 infection is actually very, very low. So most patients, young patients, athletes who are afflicted with COVID-19 are going to have the viral syndrome of COVID-19, but absolutely no underlying cardiovascular sequelae. Now, with COVID-19 as well, we're still learning quite a bit about how it impacts the heart. So there have been several autopsy studies that have shown that when you look at pathologic specimens within the heart, the mechanisms are different. It's not kind of the classic infiltrates of cells that you see with quote unquote myocarditis. The pathophysiology is a little bit different, and we don't have to get into that in this specific discussion here, but I think from a clinical syndrome, we still refer to it as myocarditis when patients present with those symptoms and with the characteristic phenomena that you see with myocarditis.
Thank you so much for walking us through that. There's been a lot of talk about myocarditis associated with vaccines for COVID-19 as well. And so I think it's always very important to talk about what is the risk from it, myocarditis or any other issue with the vaccine, and comparing that to your risk from getting the infection. And so can you talk through the differences between those, and really where does that risk balance lie? COVID-19 infection versus COVID-19 vaccination?
It's a really important point, and maybe one of the most important questions to get into in this discussion. So again, we have benefited quite a bit from studies, case series, case registries of athletes who have returned to play. That's where we gathered all this information about how common is cardiac injury after COVID-19. And in registry data sets of collegiate athletes and of professional athletes, and these are large registries actually, the prevalence of cardiac injury, as we'll call it, is around 0.6%. So that's about 1 in 200. It's about 1 in 200 competitive athletes that have returned to play and who were screened for return to play. That's the prevalence of those who were found to have evidence of cardiac injury or potential clinical myocarditis. So if you look at vaccine-related myocarditis, we know that in general, that's very rare. So the target population, if we look at epidemiologically, who's been most at risk for this, it's been in that younger adolescent to younger, age 20 or so individual, and these are particularly males. And depending on the study you've looked at, it's around 40 per million, I think is one statistic I've seen. So that's about, 1 in 20,000 to 1 in 25,000 individuals that may have vaccine-related myocarditis. And we know that these primarily are milder cases of myocarditis. So if you compare that 1 in 200 risk from having COVID myocarditis, if you will, versus a 1 in 20,000 to 1 in 25,000, specifically in this target epidemiologic range. So this doesn't include the 50-year-old male or female, their risks are even lower. But if you just look at the quote unquote highest risk group, it's not even really comparable. And that's why within sports medicine, we continue to advocate for vaccination, because it's not just the risk of severe ramifications, severe adverse sequelae of having COVID, it's long haul, right? So we know that having long haul phenomena in even young individuals, that risk is not trivial. And so for every, when you take individuals who are vaccinated, you're reducing the risk of overall cases of COVID, obviously dying from COVID, but you also have to take into consideration some of these other adverse sequelae of COVID-19. So it is really important to note that us in the sports cardiology, sports medicine world continue to advocate for vaccination. And I also want to just say, because there's a lot of I hate to say fake news, because I know that word is out there, but some of this misinformation, that's what I'm trying to say. A lot of misinformation out there that has been circulated about, oh, I'm hearing about athletes who have been vaccinated who are dropping dead after vaccination. These reports, if you see any of these out there, it's clear disinformation. Many of these cases are from individuals that had an adverse event before COVID even existed, that get put into these scare tactic videos of trying to prove that vaccinations are bad. I can attest, in my community, we communicate, we're a small community, we talk all the time. I'm just not aware of these cases out there of somebody being vaccinated and quote unquote dropping dead after a COVID vaccination in an athlete. Those reports are just not, certainly I'm not aware of them. And these videos are out there. So you just really want to be careful about that.
Thank you for that. And so again, just to point out the exact numbers that you're talking about. So risk for myocarditis among those who have COVID-19 in this age group that you're talking about is 1 in 200 versus risk of myocarditis associated with the COVID-19 vaccine is 1 in about 20,000. I have those numbers correct?
Yeah, and I want to be clear, these are coming from competitive athlete registries.
Right.
So I'm extrapolating a little bit, but I think those numbers are reasonable to compare, particularly when you're talking, at least in my world, when we're talking about the care of athletes and when I'm trying to counsel my athletic patients about when they're asking me about vaccination and what my risk is of having COVID myocarditis. We have these prevalence numbers out there when as it relates to clinical COVID-19 myocarditis.
Wonderful. Thank you for that. I think that it's so incredibly helpful to balance those risks as people are making decisions and being concerned about their health inappropriately. So, so given that myocarditis is rare, it's important for everyone, particularly those, especially with the numbers you just shared with us, who's had COVID-19 to perhaps be, slightly vigilant with some symptoms. How soon after having a COVID-19 infection would one expect to see symptoms occur, and what kind of symptoms should people be looking for?
This goes back again to the symptoms of myocarditis, and that is what we didn't know 2 years ago that we know now, which is that within that 1 in 200, most of the athletes who are ultimately found to have myocarditis had the clinical syndrome consistent with myocarditis. And it can really happen at any time. Chest tightness, shortness of breath, particularly during exertion, feeling inappropriate heartbeats, flutterings in the heart, your heart racing inappropriately, obviously getting lightheaded, dizzy, passing out primarily during exertional events, but I would say really just in general. Those are the symptoms. We call these cardiopulmonary symptoms that really dictate the potential clinical concern and the need for an evaluation for cardiac injury within the heart after COVID-19. And what we've seen primarily, at least among the athletes we've cared for, are that the majority of this population, and I think you could probably include most young, healthy people in this mix, have mild COVID. And they don't have these symptoms. They're going to have the upper respiratory symptoms, the GI symptoms, fatigue, the headache, the loss of taste, smell. These are not cardiopulmonary symptoms. And so it's those cardiopulmonary symptoms that, if experienced, and if you're a competitive athlete, for sure, those are the ones that need to be addressed prior to a return to competitive exercise. And it's important to note that not everybody who even has those symptoms, if you want to get back to exercise, that doesn't mean that everybody needs this type cardiac testing or to see a cardiologist, because most people aren't engaging in terms of the intense training regimens and the competitive environment that high-end competitive and recreational athletes are engaged in. So most people who are involved with normal exercise, the 150 minutes that we recommend of moderate level exercise, even if you have those symptoms, chest tightness with COVID, you probably don't need to have an echocardiogram or an EKG or any of that stuff before getting back to exercise. Just need to be vigilant about coming back to exercise slowly and making sure that all of those symptoms have resolved and not coming back as you kind of get back to a regular exercise routine. If you're a competitive athlete or an individual who's engaged in a lot of intense exercise training, like a marathon runner or a triathlete, and you have cardiopulmonary symptoms, that's the time where you probably want to seek a medical professional before getting back to exercise, particularly in the acute setting of being sick with COVID-19.
So I think that that's important. I'm not going to fall under the guidelines of needing to have that kind of a bunch of tests run. But what are the screening guidelines that you would specifically recommend for people who have some of these symptoms or are a competitive athlete and have had COVID and are getting back into their sport?
This is a perfect, it's like you're teeing me up here, because through the American College of Cardiology, I was actually a part of a writing committee that has updated the guidelines that we have. So this is going to be coming out later in March, certainly before our big ACC 22 meeting at the beginning of April. There have been prior iterations. They're actually fairly outdated now. So we're going to put forth kind of the most updated, what we recommend. And importantly, this kind of goes back to an old phrase of the more things change, the more they stay the same. It's a very famous quote. And really, we're trying to get away from that concept of screening. It's really the clinical evaluation of an athlete, an athletic patient recovered from COVID-19, getting back to training. And instead of screening, it's who needs to be clinically evaluated. And it's those that have those symptoms that I just mentioned. If you don't have those, then you don't need to be screened for anything. If you have those symptoms, similar to pre-COVID, if you had a bad flu, and you got back to training, you started having chest tightness, well, guess what? You're going to be evaluated by probably a sports cardiologist before getting back to your competitive training, because a doctor is going to be worried about myocarditis. And the evaluation that would be recommended would be seeing a specialist, of course, but an EKG, imaging of the heart with an ultrasound. It's called an echocardiogram, and a blood test called troponin, which we talked about in the beginning of this discussion, which is an evidence of cardiac injury. That's kind of the standard testing approach. And then there's other tests that may be indicated, particularly if any of those are abnormal or if symptoms continue on, such as a cardiac MRI, or even exercise testing potentially. But the initial battery of tests typically include those. But again, to reiterate, the guidelines are really going to emphasize that it's really only meant for those who have clinical symptoms that put you in a higher pretest probability. And for everybody else who has mild COVID, asymptomatic, or just mild symptoms, once you recover, you can get back to training with any sort of testing. Usually we recommend a little bit of a slower ramp up just to make sure that symptoms don't occur with the initiation of training. And as long as you pass that graded step up, then you're obviously back to full on training and no testing. And the majority of athletes that we've cared for really fall into that bit. We don't see a lot of athletes, thankfully, who really present with this high pretest probability, but those are the ones who certainly should be evaluated. And those symptoms are really kind of what predicts the presence potentially of inflammatory myocarditis after COVID-19. That's why we know that we can get away a little bit from the screening type umbrella term to the clinical evaluation.
Thank you for teasing out the differences with that. About how long after a COVID-19 infection would people anticipate seeing those symptoms if they have them?
Usually it could even come across during the acute setting. So whenever I see athletes, we talk about what were your symptoms when you were sick. And if they have those cardiopulmonary symptoms, and they're going to be tested. And so then it's just a matter of obviously when they're out of self-isolation and when they can be evaluated. So it's not necessarily a post-COVID type symptomatology. It's actually a part of COVID. Now, once you've recovered, as mentioned, let's say somebody was asymptomatic and they just went back to training because they didn't need testing, but during that ramp up, they start having chest tightness. Well, now we're seeing concerning cardiopulmonary symptoms. That athlete, even though they had asymptomatic COVID, obviously needs to be evaluated. So these type symptoms are highly predictive of potentially having myocarditis. That doesn't mean that there are some cases out there of individuals who may have less concerning COVID-19 symptoms or a mild COVID-19 course and maybe have myocardial involvement. And that's, again, focusing on that graded return to exercise training. And if we see those symptoms, those cardiopulmonary symptoms, now that individual should be evaluated.
Very good, thank you. As we wrap up today and we talk about the really high numbers of COVID that we still have circulating, granted those numbers are coming down, which is great news. What kind of long-term effects do you think we're going to see on cardiac health for people who've had COVID-19?
That's a really good question. And I wish I had the answers to that right now. I don't. Again, I think reassuringly, having COVID-19 with a asymptomatic, mild, or even a moderate course with high fever, systemic symptoms, but lack of cardiopulmonary symptoms, those individuals who recover and feel fine, I don't anticipate we're going to see long-term outcomes. Even with myocarditis, again, myocarditis is a disease that's been around before COVID. And individuals who have myocarditis, unfortunately, some can get very, very sick. We call this fulminant myocarditis and can even die because they get so sick with it. But there's a wide spectrum, and probably most individuals who have myocarditis get better, and there are no long-term cardiovascular sequelae. We talked about vaccine myocarditis. The overwhelming majority of those cases we know are mild cases of myocarditis. These individuals recover with no long-lasting sequelae. I think the arena that's to be determined, obviously, the post-acute sequelae of COVID-19 or the long hauler, and what happens with those individuals who unfortunately suffer from that over the long haul. Those that have more severe forms of inflammation of myocarditis and maybe have scarring in the heart that may kind of be a long-lasting remnant of the myocarditis. I mean, these type of individuals are ultimately it's going to require long-term follow-up to kind of see outcomes in these individuals. But I've been reassured just taking care of competitive athletes for the last 2 years who have had COVID that really the vast majority get better and have returned to competitive play with no long-lasting effects and are really back to baseline to where they were before COVID-19.
That's wonderful news. And, we haven't always had great news throughout this entire pandemic. So thank you so much for sharing with us your expertise and the things that we should be watching for, both risk from COVID as well as risk associated with COVID-19 vaccines, which are really, thankfully, very rare. So Dr. Kim, we appreciate you. For everyone watching, as we think about COVID-19 risk, we need to always be considering both our personal risk and our long-term risk for long-term complications from COVID-19. So I appreciate you talking with me today about cardiac risk, particularly among our athletes. And for everyone watching, please keep doing what we know will keep you safe from COVID-19, which is getting a vaccination, getting a booster if you are farther enough away from your original series of COVID-19 vaccinations. Stay safe, everyone, and thank you for watching.